This episode is brought to you by Hospital Medicine 2020, the Society of Hospital Medicine's annual conference, April 15th through 18th in sunny San Diego. Don't miss the largest hospital medicine meeting. Register now at shmannualconference.org and use the code Curbsiders to receive a $50 discount. We're also sponsored by Primary Care Internal Medicine of Ithaca. They are looking for a primary care physician to join them in beautiful upstate New York near the Finger Lakes. Email arcostello, Costello, @gmail.com to learn more about this great opportunity.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
This episode of The Curbsiders is brought to you in partnership with the Society of Hospital Medicine. Members can claim CME and mock credit at www.shmlearningportal.org/Curbsiders. Well, Paul, we're back.
Hi, Matt.
Oh, and Stuart's here too, of course. So this is The Curbsiders. This is Things We Do for No Reason, Part 3. Paul, can you tell them what we do on this show?
Sure, ever so briefly and without chiding. This is the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge.
And with us tonight is our expert producer, Dr. Justin Lee Burke. Justin, can you tell them the specific topics for tonight and introduce our guests?
Absolutely. We have another excellent Things We Do for No Reason episode where we talk about high goal light potassium replacement. We talk about supplemental oxygen and antipsychotics for delirium. We have two returning guests, Dr. Lenny Feldman and Dr. Tony Breu, Things We Do for No Reason experts. They are co-editors of the Things We Do for No Reason series in the Journal of Hospital Medicine. They are lovely and are just wonderful teachers. So without further ado, let's get to it.
Lenny and Tony, this is your third time back. We are thrilled to have you here. These are really popular shows. The audience loves it when we have you guys on to talk about things we do for no reason. We're going to get all into that, but Lenny, we'll start with you. Give the audience a one-liner, remind them a little bit about yourself, and then we'll go to Tony next.
Sure. Thanks for having us back on. We really appreciate it. So I am almost a 47-year-old. I am 2 days away from 47. A husband, a father of an incredibly energetic and cute 15-month-old, a baseball fan who is still in a major depression because his baseball team is no good, who loathes dogma and can't stop watching stupid political shows.
Okay.
Nice.
Like impeachment things.
Tony?
Yep. So I'm 41, interestingly, 5 days from my birthday, and a father of two, husband to a brilliant endocrinologist. And I also happen to be listening to all this impeachment coverage to and from work, and I can't say that it's lifting my spirits.
Guys, I want to say I'm 6 days from my birthday, so
This is weird.
it's basically a birthday episode.
And so tell us your feelings about impeachment.
So there will be cake at the end of this episode.
Yeah.
But to celebrate all your birthdays, why don't we talk about some picks of the week? And let's start with Lenny, since he's closest to his birthday.
Wow, thank you. And my guess is you probably heard this pick of the week already in the last couple months, and I don't know for sure. So I'll do two. One is I did make it to a movie, even with a 15-month-old. We made it to a movie over the holidays, and we saw Knives Out. If that has not been a pick for the week.
Did you bring your 15-month-old to that one?
We did not. We left him with his grandparents. And it was very enjoyable. I would recommend Knives Out. And then a book to recommend that's relatively new that I have been reading is Priced Out, which is Uwe Reinhardt's book. It came out posthumously because he died in 2017, and it came out in 2019. And Uwe Reinhardt writes a great book about understanding the economic and ethical costs of American healthcare. So if you want to get a good sense of why we pay what we pay for things, it's a good book to read.
Oh, that sounds great. Have not heard of that one. Oh, wait, Tony, how about you?
So right now I am listening to Crisis in the Red Zone by Richard Preston. So Richard Preston also wrote The Hot Zone, which was about the Ebola outbreak in Western Virginia in the 1990s. And so this is about the Ebola outbreaks in 1976 and 2014 in Africa. And it's the amazing thing is because it's a true story, as you listen or read, it's even more frightening. But it covers ethics, politics, obviously medicine. It's just absolutely riveting. It's fantastic.
Justin, what about you?
Yes, I have a new favorite internal medicine medical education podcast, or at least second favorite. It is the Cardio Nerds, that's created by two extremely intelligent cardiology fellows, Amit Goyal and Daniel Ambinder, both who were my seniors when I was a resident. And they are very good at taking very complex cardiac concepts and making them very simple. I really wish I had it to listen to right before going into a CCU rotation because I would have felt a lot less embarrassed from my first aortic stenosis admission. But it's definitely worth checking out. Cardio Nerds, very good stuff.
Cool. Paul and Stuart, before we get on with the show, did you guys have any burning picks of the week, Paul?
Nah, nothing burning.
I've got something burning. Yeah. So stories. In honor of the amazing novel coronavirus, I have a semi-documentarial film. It's directed by Wolfgang Peterson. It came out in 1995. It tells you how to survive one of these outbreaks. It's called Outbreak. And I'm sure Paul would have something to say about this movie because I frankly don't.
Have you seen the movie? Or did you just actually Wikipedia the word outbreak and you were just praying to God I would have something to say about? Is it Dustin Hoffman?
It is Dustin
Renee
Hoffman.
Russo.
Yeah.
Okay.
Yep.
That's all I have to say.
I saw it in the 90s. That's all I can say.
I don't believe you. I don't think you've ever seen the movie. I don't.
That's actually.
I think you're laying eyes on it for the first time tonight.
That's not
that
true
Dustin
at all.
Hoffman movie is just not very good.
Yeah, I don't think it was critically loved, if I remember correctly.
No, it was not.
So rather than a pick of the week, it's a movie that you've heard of.
I saw it in a drive-in. It was a twofer. So you had Dustin Hoffman as an action hero in Outbreak.
Sure.
And then it came with it was Bridges Over Madison County, which had Clint Eastwood as a romantic lead.
Oh, it's perfect.
I thought you were going to say Rain Man was.
Who?
Okay, I think we
Who
better
is
get...
this drive-in for? Like, what? What demographic are you targeting with Outbreak and Bridges of Madison County?
Paul, I think we all know we'll never answer that question. A reminder that we're brought to you by Hospital Medicine 2020, the Society of Hospital Medicine's annual conference and the only conference dedicated to hospital medicine. HM20 will be held April 15th through 18th in sunny San Diego. The articles featured in this episode are part of the Things We Do for No Reason series in the Journal of Hospital Medicine, the official journal of SHM. For more Things We Do for No Reason content like this, attend HM 2020 this spring. It offers an expanded schedule with more repeated sessions so you don't miss out on the hottest content. And also check out the Sim Center and new technology track this year. HM20 is pacing to be the largest hospital medicine meeting to date. So register now at shmannualconference.org and use the code Curbsiders to receive a $50 discount. Let me remind you that our sponsor today is Primary Care Internal Medicine of Ithaca. They have a wonderful opportunity to join them as a primary care physician in beautiful upstate New York, near the Finger Lakes, near wine country. This is a great practice. They have flexible hours. They are open to job sharing. You can take as much time as you need with your patients. You will become part of a close-knit community of medical professionals, all while living in a college town in upstate New York. It's a great place to raise a family and to practice medicine. If this sounds exciting to you, and it should sound exciting, then please email arcostello, COSTELLO, @gmail.com to learn more about this opportunity. Justin, can you start us off with a case?
Absolutely. So we have our first case is a Mr. Eric Lokay. He is a 40-year-old gentleman. He's admitted to Cashlack Hospital with a STEMI. He had a heart attack. It involved the inferior region of his heart. He had a stent that was successfully placed and his troponin peaked at 20, but is now downtrending. Overnight, the CCU nurse calls to say, his potassium is 3.7 and magnesium is 1.4. I think you must have forgotten to activate the replacement protocol. Are you going to, quote, buff the lights? So, Lenny, for a patient like this, can you go through what are the current guidelines on electrolyte abnormalities in patients that come in with a heart attack?
Yes, so that's a great question. So first of all, probably the potassium, we would all say relatively normal range in most hospitals. I think in Kashlak is 3.5 to 5. I think we could all pretty much agree on that. There are some people who will say it goes up to 5.5, but most of us use sort of that 3.5 to 5 as the normal potassium level. And then exactly what the potassium should be in an acute MI patient, there really aren't great guidelines on this at all. The European Resuscitation Council guidelines for resuscitation in 2015 said that there's no universal definition for hyperkalemia. They defined hypokalemia as less than 3.5. They went for hyperkalemia greater than 5.5. But in general, most of the guidelines, back in 99, there was some reference to trying to buff the lights to get them to be greater than 4. But then most of the guidelines, and that was AHA, ACC, most of the guidelines then became if you have ventricular fibrillation or ventricular tachycardia and you are trying to prevent recurrent VFib or VTAC, then you probably want to get the potassium greater than 4. But there's really no guideline that says you should be for a patient with acute MI, a specific potassium of greater than 4, although we are all taught that. I don't know if there's anybody who's not been taught in internal medicine that you need to get the potassium greater than 4 in an acute MI patient. And there's the National Council on Potassium in Clinical Practice. And so if anybody is part of that, I'm sorry if I'm bringing it up and poo-pooing it at all, but they say that patients with cardiac arrhythmias, you want to get the potassium greater than 4 and make sure you give some magnesium with it. And there's a study, there are recommendations from this dude, McDonald et al., who said it would appear wise to avoid potassium levels above 4.5, but that group thought that you should try to maintain a serum potassium above 4.5 during acute MI. But no major organizations tell us where we should be in the acute MI patient. We're just handing this down from generation to generation.
Yeah, the curious thing, too, to me is, okay, it's one thing in acute MI, and as you pointed out, the guidelines, even in the acute MI guidelines, they're like, if they've had these two lethal arrhythmias like VT, refractory VT or VFib, then, it's reasonable to aggressively get the potassium and magnesium to 4 and 2. But everyone seems to do that for like every medically ill patient in the hospital.
Yeah, I think it started in our acute MI patients, and then as many things that start in the ICU, it then is brought to the floor and we start generalizing it to everybody, and it just sort of gets a life of its own. And so they started with these topics or with these studies in the mid 80s where they started looking at patients. And I think this is kind of where the potassium greater than 4 came from. They started with these really small studies. There's one study like this in Circulation where they only had 60 patients. Back then, you could get in Circulation with a study of 60 patients.
And it probably had a horrible name, too. Nothing clever.
They did not have some great acronym that went with it. And they looked at 60 patients who came to the CCU within 12 hours of their first AMI. And they were excluded if you got anything like DIG or beta blockers or calcium antagonists or antiarrhythmic drugs. And basically all the patients were treated with were, because this is the standard of care back in the 80s, oral diazepam, oxygen, which we'll get to in a little bit, morphine, and no one usually got electrolyte supplementation. And so they checked the electrolytes on admission, and then they followed continuous EKGs, and they wanted to see generally, do you have arrhythmias? And what they found was that, yes, And it was the potassium that they were looking at was the admission potassium. That's it. All of this is related to the admission potassium, not mean potassiums during the hospitalization, not the potassium when the patient had an arrhythmia. What was their admission potassium? And they did see in their studies that as the potassium went lower, there was more of a risk of VT. And they thought that serum potassium concentration at admission was an independent predictor variable for VT. And it's studies like this, a bunch of them in the mid-'80s, that then people said, okay, then we must need to get our potassium greater than 4 to avoid VT. And this is not about mortality at all. This is about VT. But we decided to extrapolate to mortality.
So Lenny, what's the risk? What's the risk to pushing the potassium?
So you guys didn't ask at the beginning what our biggest failure was, but I'll tell you one of my big failures, and I think this is part of the risk. And my wife likes to remind me of this patient on a relatively regular basis. When I was a resident at Kashlak many years ago, since you can begin to time it since I'm turning 47, I had I think it was a second year resident, and it was the first time I was leading a team, and it was over the weekend, and my interns were gone, and I had this elderly patient that I was getting ready to send to a SNF, and he had a low potassium on the day I was going to send him to the SNF. So I saw low potassium less than 4. It wasn't super low, but it was low. And so I said, I need to supplement the potassium. So I gave him some IV potassium. I can't remember exactly. I assume it was IV potassium to get that potassium up. And then they came to take him off to the SNF, and he was dead when they came to take him off to the SNF. Yes. And my wife likes to remind me about that patient on a pretty regular basis. And I think that's one of the things we need to worry about. You give potassium to a patient in a bolus, and bad things can happen if their heart is already pretty excitable. So the concern is changes in potassium can really affect heart activity pretty rapidly if we're not careful.
It's hard to beat that failure.
Yeah, that was a bad failure. So we finally started getting some better data about this stuff in 2012, because really we had been running with these kind of small studies from the mid-'80s until we started getting observational studies in early 2012. And Goyle et al., I think many of us remember the study that came out in JAMA, where these are all retrospective and they're all observational, but they're pretty large. This was a study of about 40,000 patients with acute MI from 2000 to 2008. Again, they also looked at the admission potassium, but they also looked at the mean potassium during the hospitalization. And this was at a bunch of different hospitals. This was 67 hospitals that they looked at. And they wanted to, again, correlate this admission and the mean post-potassium with both arrhythmia and with mortality. And we finally had a study that was a really big study to look at. And what we saw was, in general, that if you had a potassium of about 3.5 to 4, you had the lowest mortality. And it was right around the mortality of having a potassium of 4 to 4.4. But if you started getting above 4.4, 4.5 in that 4.5 to 4.9 category, mortality went up to about 10%. And if you went below 3.5, mortality was at about 11%. So you get the sense that this is a U-shaped curve where that 3.5 or the 3.5 to 4 and the 4 to 4.4 is sort of the bottom of that curve. And on either side of it, mortality starts to go up, as does the risk of ventricular fibrillation. And so that was one of the first signs that maybe buffing the lights actually can lead to real harm, and not just anecdotal stories like I gave of my patient in residency.
That paper has in the introduction, the authors kind of speculating, saying that most of the studies that found these potassium associations were the older ones, were before there was like routine use of beta blockers and reperfusion therapy. and like the early invasive stuff that gets done now for acute MIs, and that in the current era there's like less of these like post MI arrhythmias than there used to be because we have better therapy now.
Oh, I think that's probably absolutely true. I mean, I told you what the therapy was back in the mid-'80s. With
right. You said Valium, I think.
And oxygen.
Diazepam, whatever.
Yeah, please. No trade names, Matt. Remember where you are.
Yeah, it was my own rule.
But yeah, we weren't doing very much for those patients. And now we have really great guideline-directed medical therapy that I think lowers people's mortality very significantly. And we don't know how that interacts with potassium levels, particularly their admission potassium level.
So sometimes it's helpful to offer an alternate explanation, right? So one explanation is obviously that the low potassium is causing these arrhythmias. And an alternate explanation is that it's an epinephrine phenomenon and it's a confounder. And so the way you might explain that is the patient who on admission has a low potassium, that is an indicator of a lot of catecholamines, because catecholamines turn on the sodium potassium ATPase and shift the potassium into the cell. And so the catecholamines also may be the things that are leading to the arrhythmia. So there's other ways to explain the association between low potassium levels on admission and the subsequent VTVF, and you don't have to say, look, it's the low potassium that was the cause.
So you're making an argument for diazepam is what I'm hearing here.
That's exactly what I'm doing.
Potassium should help. I think potassium should help.
Well, hopefully he's making the argument for a randomized controlled trial.
Also beta blockers.
Yeah,
I mean, that's why
one
of the reasons why beta blockers work.
Sure.
But it would be nice to be able to limit the question to are we buffing potassium or are we not buffing potassium, rather than have all the other confounders in the mix.
Right. So Lenny, give us your expert opinion. Potassium, less than 3.5 in a acutely admitted medical patient. What's your threshold to give repletion, and like which patients should we not be repleting?
All right, so it's a hard question because this is, again, all observational data. So
sure.
These are all patients with acute MI. There's also some studies on patients with unstable angina and STEMI kind of pictures. Again, it looks like similar data. So I would say the patients who are between 3 and 3.5, we should replete. It seems based on the observational data that 3.5 to 4 is a good threshold to shoot for. And then if they're 4 to 4.5, that's fine as well. Certainly don't try to get above 4.4 into the 4.5 and above category. So that's again, our patients with acute MI. And then you can start talking about other patients. There's been some studies relatively recently of ICU patients. There's been some studies of patients with acute decompensated heart failure. Again, with very similar data that the 3.5 to 4 patients seem to do better. But again, this is all observational data that we don't know in the end what really the right thing is, except that's the best data we have.
Okay. Anyone else? What are you going to do in your practice, Tony, based on this? Are you going to keep the potassium between 3.5 and 4.5 and call it a day? Replete to at least 3.5 and call it a day?
Yeah. So what Lenny does or is recommending is similar to what I do, which is I look for the patients who are at high risk, the patients who have acute MI. What the data doesn't necessarily support acute heart failure as strongly as acute MI, but I generally lump those patients in, and the patients who have cirrhosis at risk for hepatic encephalopathy. I have a slightly higher goal for them, over 3.5. Otherwise, over 3, I'm comfortable with.
Mm-hmm. Okay. Yeah. Sometimes I factor in, like, if I'm giving them IV, loop diuretics twice a day, then I'm going to want it at least like 3.5. And if it's like 3.3, I know I have to give them repletion because it's going to drop. I don't want it to drop lower.
Yeah, and some of the studies look at sort of the variability, the changes in potassium during the hospitalization. And it does seem that the greater the variability, the higher the risk for patients. Mm-hmm. But some of that is we can't really control, right? If you have a patient who's in for heart failure and you need to diurese, and you know that they are potentially likely to get have big changes in their potassium because of it.
All right, here's my segue. It's KO. All right. So Case number 2, Margaret Bohr is a 28-year-old female with a history of asthma who presents to the emergency department with a shortness of breath. She has a respiratory rate of 25 and an oxygen saturation of 94%. She has then started on 2 liters of nasal cannula, O2, off the wall, which improves her O2 saturation to 99%. We're feeling great about ourselves. And I got a question for you, Tony. So oxygen is great for you. It's good for you, right? Or at least it's harmless. Isn't that right?
So that's obviously a loaded question. So oxygen is good for us. I think all of us on the call, all of us who are listening absolutely need oxygen. But I think the thing we either haven't quite learned yet or have learned but sometimes forget is oxygen can be harmful. So there's, I think, a couple things that we have to talk about for this topic. And the first is that as we increase supplemental O2 to patients, we do a very, very good job of increasing PO2. Okay? So if you turn up the O2 and you increase someone's PO2, right, the partial pressure of oxygen from 100 to 500 millimeters of mercury, in that exact change from 100 to 500 for PO2, you've increased the total content of oxygen by just 6%. Right? So the tissues, even though your PO2 has gone from 100 to 500, they're only seeing a 6% increase in actual content of oxygen. Okay? And so we're actually not delivering that much more oxygen to the tissues when we turn up the O2. But the problem results from the fact that the sensors that react to oxygen delivery react to PO2. Okay? So as we increase the supplemental oxygen, we turn up the nasal cannula, we put them on a mask, we do a fantastic job of increasing the partial pressure, increasing what the oxygen sensors are going to see, but we're not actually delivering any more oxygen. And it's this sensation that the PO2 sort of tickles that becomes problematic. So before I talk about that, questions about that first piece that any of you guys have? That makes sense?
You're saying the sensors in the pulse oximeter that people are wearing on their fingers is picking up the increase, we're buffing the numbers there. Is that what you're saying?
Or the biologic sensors, like the sensors.
The biologic sensors.
Yeah,
Okay.
So I'm talking about pulse sensors, right? So these
Let's not.
the hypoxia-inducible factor, right?
Yes.
The sensors in the endothelial wall.
I got it.
Right?
Okay.
So that leads to the second thing that we have to remember, which is that when you increase the PO2, the reaction by the vessels is to vasoconstrict, right? And the reason to vasoconstrict is that oxygen is toxic. And to be a little bit more precise, oxygen's free radicals, right, the superoxide and the hydrogen peroxide, those things are toxic. And so when you increase the PO2, what you're telling the tissues is, wow, we have a lot of this toxic molecule coming our way, and we're going to vasoconstrict to protect the tissues from this toxic molecule, again, really, that the free radicals that result from this toxic molecule. So what you're doing is you're turning up the O2. We all do that. We increase the PO2, but don't really increase the content. We've increased it by like 6%, right? We haven't increased the content that much. And then in response, the vessels vasoconstrict and decrease the delivery of blood to the tissues because they don't want to see all this oxygen we're trying to give it. Does that make sense so far?
Yep.
Okay.
I'm sorry, when you say the 6% that goes up, that's the 6%... What
total oxygen content. And so what I can do is Justin, I can send you some a really amazing editorial written by Joe Lascalzo, who's the chief of medicine at Brigham, in response to the randomized trial published in the New England Journal in 2017. I'm taking his calculations that are showing these changes in oxygen content. And I'll send you another paper that shows the oxygen hemoglobin dissociation curve. And it has this additional line for total oxygen content. And what's amazing about it is it's essentially a flat line. It does not go up even as the PO2 goes up from 100 to 500. Does that help, Justin?
Yeah. Very.
Okay. So tissues say, I don't want all this oxygen. I'm going to protect myself and I'm going to vasoconstrict. Okay? And so what that does is it leads us to the evidence for harm. And there's actually been evidence of harm dating back to the 1800s. James Lorraine Smith put birds in chambers and gave them increasing oxygen contents, and short answer is they did not do well. They had convulsions, they died. And then there's experimental data going back to the 1940s showing that when you give increasing FiO2, there's vasoconstriction of the arteries feeding the brain, unsurprisingly, so there's decreased flow to the brain. And the same is seen for coronary arteries in studies in the subsequent decades. So we have all this good sort of physiologic data, but it's hard to overcome this idea that, at least in the setting of something like an acute MI, oh, well, this is hypoxia of the heart. Clearly, we want to deliver more oxygen, so let's just turn up the FiO2. But again, the problem is the same phenomenon happens to the coronary arteries. They vasoconstrict in response to increasing PO2 in many ways to protect the heart from these toxic oxygen.
Wow. So this sounds great, from a theory standpoint and in animal models, but is there any evidence in practice of oxygen harming patients?
Yeah, so let me offer a couple studies. So in the acute MI patients, and I think everyone who's on this call probably learned MONA in medical school, right? Acute MI, morphine, oxygen, nitro, and aspirin. And I think a lot of the listeners probably heard MONA. And so EMS, emergency medicine, admitting hospitalists all put patients on oxygen. And we began to chip away at MONA over the last decade. And supplemental oxygen is one of the things we've chipped away at. And the study I'll offer you is this randomized control trial from 2015 published in Circulation. And what they did is they took patients who had an O2 under 94, and they gave them either 8 liters of oxygen or no supplemental oxygen. And the really interesting thing is that the patients who got the supplemental oxygen had an increased risk of recurrent MI and a larger infarct size. Going along with this idea that if you give them more oxygen, the coronaries constrict, amazingly enough, to protect from all that extra oxygen.
Do you happen to know if there is also correlation with magnesium deficiency? Reason being is because magnesium deficiency, it increases the expression of inducible nitric oxide synthase and would further exacerbate the free radical oxygen-mediated vasoconstriction.
It's a question I don't have the answer to, at least in this trial.
Sure.
And Stuart, your question is a good one because what these reactive oxygen species are doing is decreasing nitric oxide. Right. That's exactly right. What they're doing to reduce the vasodilation. So it's in many ways a reversal of vasodilation. There have been subsequent studies. There were actually studies before this one in 2015. There are studies in critically ill patients showing harm to oxygen. And I think all of us know that there's harms when you just turn up the O2 in patients who have acute exacerbations of COPD. So it's not just patients with acute MI.
Yeah.
Can you talk?
Go ahead.
I was going to ask Tony if he could talk a little bit about how the oxygen, it differs a little bit in the lung, right? The way that oxygen affects blood flow in the lung, doesn't it?
Yeah, so I think we've all heard of hypoxic vasoconstriction in the lung, right? So if I'm poorly ventilating an area of the lung, I don't want to deliver oxygen to that area, so we vasoconstrict. And my understanding is it's complex as to why the lung and the systemic circulation react differently, but I think it has something to do with this hypoxia-inducible factor. Mm-hmm. But undoubtedly, they do react differently to low oxygen tension.
Yeah, and the article that you guys had sent us for the Things We Do for No Reason article had mentioned that could potentially, if you're giving oxygen, it could open up these areas of the lung that are not getting good blood flow, and it could cause actually like some type of shunting and actually kind of worsen things. I just thought it was interesting. I didn't fully understand all the physiology, but it seemed like it was a lot more complex than I thought about how like you could make a patient with COPD worse by really pushing the oxygen.
Yeah, so the patients who have acute COPD exacerbation are placed on oxygen. I think we all say, be careful, they might become hypercarbic. And what I learned in medical school and said throughout residency is the physiology of that was the quote-unquote loss of hypoxic drive.
Same, right? Same.
Yep.
And that is almost certainly playing a role, but it's actually the loss of hypoxic vasoconstriction that is probably a greater contributor. And it's not something that we can probably easily explain without pictures and diagrams. But I think the key thing for the listeners is this hypoxic vasoconstriction in the lung, as opposed to hypoxic vasodilation in the other areas, is a contributor to the hypercarbia in acute COPD.
Okay. Thank you.
What are we to do with this? So, all super interesting, but I'm a dumb guy. I'll be the resident dumb guy here. Just tell me what to do, Tony. That's all I ask.
Yeah, so there's some great recommendations published in the British Medical Journal in 2018, which we can also put in the show notes. And their strongest recommendations were for patients with acute MI and acute stroke. Because remember, the same way that the coronary arteries vasoconstrict, the cerebral arteries do. And they came down very hard that you do not want to give supplemental oxygen if they're above 92, strong recommendation. And a weak recommendation, you do not want to give supplemental oxygen if they're over 90, right? So you can probably safely, in a patient with acute MI, acute stroke, hold off on oxygen assuming they're over 90, okay? Everybody else, the patient with a pneumonia, the patient with cellulitis, they don't come up with a lower limit, right? They don't say start at 90, but they say definitely turn off or down if they're over 96. Okay, so if we're rounding, the patient's hospitalized with acute pancreatitis, their oxygen is 92 and they're on supplemental, turn it down or off. Okay, I generally, this is my practice, this is not quite what the guidelines say. I essentially do 90 or above for everybody. Meaning, if you're 90 or above on your own, I'm not giving you supplemental O2.
Right.
Okay. And I lower that for the patient with acute COPD to 88. Okay. So strong recommendation for 92 or above for acute MI or stroke. Weak recommendation, 90 or above for MI or stroke. And then I think 96, I think what we have to have in our mind is if you're over 96, you've got to turn them down.
Yeah.
Paul, our good friend Erin Naruski made a point, on one of our shows at Chest, she made this point that the symptom of dyspnea is not necessarily treated by oxygen, because a lot of the time dyspnea, there's a different mechanism. It's not hypoxemia that's like causing the person to feel short of breath. It might be something else. It might be fluid. It might be a pneumonia in their lung. And you kind of have to treat the underlying cause, but giving oxygen is like maybe buffing the numbers again, but not necessarily going to help their breathing problem.
Right.
But yeah, there's some patients who do report a subjective improvement, and I don't know if there's some positive pressure that comes along. I can't imagine 2 liters of nasal cannulas giving a positive pressure, but it's hard to. Some patients do report subjective improvement, but I think to routinely use it for that sensation of dyspnea, that's incorrect. Mm-hmm. We should not do that.
But Tony, what do we do about that oxygen ferry that comes along at night, and you've taken the oxygen off your patient, and you get there in the morning and the supplemental oxygen is right back on.
And then you can't transfer them.
So there are a number of people who posted on Twitter these great pictures of, you know how in hotels they have the things that hang from the door saying like, do not disturb? What they've done is in some hospitals, they've put those on the oxygen system.
Oh yeah, like a hang tag on that. Right.
Exactly.
Tape it on the patient's forehead. Yeah.
Exactly. So you could tape it on their forehead, or you could put it on the actual thing where they turn the dial up or down, and it says, "Here are my goal O2s." And I just think that's you
brilliant.
You got to go right to the place where the problem is happening, and it's at that dial.
Yeah,
and I think that's the way to go.
And the sad thing is, it's a well-intentioned person for sure.
Of course.
And it's probably the technician that's checking the vital signs and being like, oh, their saturation's 92%. It should be 100. And they put them on 4 liters or something. You know, it is
absolutely.
It's a shockingly hard thing to do, to wean someone off oxygen in the hospital. Like, you have to tell a lot of people. So maybe the hang tag is like, high enough up the chain of things that it would work.
Maybe even harder than taking people off telemetry.
Getting DocuState off your formulary also very challenging.
That's
But
impossible.
and I think we're also obligated to counsel our patients. Just like with a blood pressure of 180 as a solo reading, patients freak out about that.
Yeah.
We're obligated to remind them that a single reading, if you're asymptomatic, is okay. Same here. I think sometimes we don't tell our patients it's okay if you're 92% on room air. You do not need to be 100.
I think we did a pretty good job on this one. So if you want to, Tony, you want to recap the recommendation just one more time, your recommendations for your lower limit and then your upper limit?
So my personal is I don't start supplemental O2 if they're above 90.
Okay.
That's the easiest way to do it. And I actively wean certainly if they're over 96. Like you got to turn it down or off if they're over 96. And then I'm a little bit more lenient for acute COPD 88 or above.
Okay.
I've definitely been using the 88.
Okay.
And then I have an acronym for free radical formation. It's O2MG, and that's a good segue to our next case.
Okay.
That one more thing, or just to make sure, because I know I feel like residents have talked a lot about this IOTA trial or the IOTA analysis.
Oh, yeah.
I don't think we mentioned, but just to kind of put in there, and Tony, correct me if I'm wrong, but essentially there was a very large Lancet study that did a meta-analysis that did kind of confirm that having a saturation above a certain level, 94 or 95, was harmful and even led to, I believe, death at 30 days.
Yeah, so I'll make a very brief comment about this. As you get to 95 or above, this is where you begin to have those PO2s that increase without any increase in oxygen delivery. So that's why this 95 is an important number. You're giving them a lot of PO2, but you're not giving them any more oxygen, which is counterintuitive, by the way. So you guys I think the listeners need to look at the figure that hopefully Justin will put in the show notes.
You got it.
Justin, I didn't know you had any iota what that was about.
I knew that was coming. Was ready for it.
That's stupid.
Expected it from Stuart, disappointed from Lenny, but I'll take it either way.
I think Stuart gave Lenny the bounce pass on that one.
I appreciate it.
I'm okay with that.
Yeah.
Jerks.
Paul, did you want to read the last case?
Yeah, I guess. I feel like
Paul, if you want to take the rest of the night off, Stuart and I got this.
I mean, no, it's just the name. I feel like you saved this one for me because the name is the most aggressively dumb of all the cases. But we'll power through. It's fine. So this is our patient Hal Dahlman, who is probably otherwise okay. He's an 82-year-old guy. He's got a history of dementia. He's presenting to the ED with shortness of breath. He is diagnosed in the ER with pneumonia, admitted to the hospital service. And overnight, on his first night of admission, he pulls out his IVs. He starts wandering around the hallway. He's clearly disoriented. The nurse calls the resident and says that the resident needs to give this patient something for whatever's going on here. So I guess before we decide what to treat with, we should probably discuss what we're treating. So Lenny, what is going on here, and what is the nurse asking of us exactly?
Sure. So it sounds like this patient is probably delirious. And so let's define delirium. I think the important thing to remember, there's a few different parts of it. One, it needs to be an acute change, usually fluctuating in cognition, that's characterized most importantly by inattention. So it's not just someone who doesn't know where they are. It's way different than dementia. These are people who are not attending to you as you're speaking to them. And it's typically associated with some disorganized thinking and or alterations in consciousness. So the real important parts is it's acute and almost always involves inattention. And so then you have to think about ways of trying to diagnose it. And this brings me to two of my favorite tests, because I think it is incredibly easy to do, and you can do some quick and dirty kind of stuff. So does anybody have sort of favorite tests that they use for delirium?
Head CT.
Your analysis, sure.
So there are bedside tests, where we can talk to the patient. And so one of the first things we want to do is rule it out, right? And so this is kind of the D-dimer of delirium tests. There are two tests you can give. You can ask what day of the week it is, and you can ask them to do the months backwards. So what day of the week it is and months backwards. The sensitivity for delirium is 93%. The specificity is about 64%. So this is a great way of ruling out delirium. If someone's able to tell you what day of the week it is and then do the months backwards, they're not delirious, or very unlikely to be delirious. Now, delirium, it depends on what sort of, whenever you use your sensitivity and specificity and come up with likelihood ratios, it's all about what's your pretest probability. And up to a third of our patients who are older than 70 will become delirious in the hospital. So you could come up with a sort of pretest probability of around 1/3 of your patients. If you do that and you use the 2 tests that I talked about and they are negative, then your likelihood of delirium is down to about 5%. So you've gone from 33% down to 5%, and that's pretty darn good. If they don't answer those correctly, then your post-test probability is around 55%. So you're still not sure that they're actually delirious, and you can start using some other tests at that point, like the 3D CAM, which came out, I think, in 2014 in an article in Annals of Internal Medicine, which is uses a bunch of different features to try to make the diagnosis. But in general, start with those 2 tests that I talked about, and if they're positive, then go on to do more testing to decide if you think that they are delirious or not. But all of this is asking them things and observing things, not sending them for head CTs.
Yeah, Justin, come on.
Got it. NCTs.
Do the MRI next time.
Can you send the article, Lenny, about the specificity sensitivity of the?
Sure. Yeah,
that'd
that's
be
a
great.
Journal of Hospital Medicine.
Oh, wow.
Yeah, we like that journal.
Yeah, they're great.
All right.
Let's let's talk about this then. What has been what's the evidence that antipsychotics are a good idea in delirium?
So I think when you talk about delirium in the hospital, there's a couple things to think about. One is, are you trying to prevent the delirium? And so there's a whole bunch of data on prevention of delirium. And what I'll tell you for the prevention of delirium is there's really no good data that there are any good medications to prevent delirium, except for maybe, possibly melatonin.
Yeah, I like that trial.
Maybe, possibly melatonin. And so you can think about using melatonin. There's a relatively recent trial on melatonin that used melatonin, but
it was a very low dosage, though. It's like 0.5 to 1.0. I can pull the trial.
So there's a Rameltion trial ICU treatment study. This was in 88 ICU patients. And they seemed to find they would give this at basically 8 p.m. every night to see how the patients would do. And they found that using Rameltion, which is a type of melatonin, just acts on some of the melatonin receptors and not others that melatonin acts on. Rameltion tended to decrease the duration of ICU stay, as well as decrease the occurrence rate and duration of delirium, and it was statistically significant. They were using an 8 milligram dose in this study. So it may work, and I think there's very little downside to melatonin that people are finding. I think one of the pearls for melatonin, and we actually tell this to the residents, because when residents are changing from night to daytime schedules, it can often be very difficult to then fall asleep. We will tell the residents that it may be easier to fall asleep after you've gone from nights to days if you take melatonin or Rameltion about 3 hours before you try to go to sleep. So don't take it at 10 and think you're going to fall asleep at 10:30. Take it at whatever, 7 or 8, and think you're going to fall asleep 3 hours later.
So the trial that I know about was published 2011. It was a randomized controlled trial, 145 individuals. It reduced the incidence of delirium from 31% to 12%, treating with 0.5 milligrams of melatonin at, I believe, 6 p.m. I'm trying to pull up the article itself.
Yeah, the other article that I found about this was this interventions for preventing delirium in hospitalized non-ICU patients. It's a Cochrane review from 2016 by Siddiqui, and that included 3 studies of melatonin, not the fancy Rameltion, whatever it is. And that said they couldn't find, they didn't think there was clear evidence that melatonin reduced delirium. They didn't comment on the prevention piece though.
Now, the Journal of Clinical Anesthesia in 2020 just did the effects of melatonin on delirium and hospitalized patients, a systematic review and meta-analysis.
So that one. Okay, so that
and
one.
they say in the summary, the results of this meta-analysis of 16 trials neither support nor oppose the use of melatonin in the prevention of delirium of hospitalized patients.
Really planting their flag. Good.
Exactly.
All
but
right.
it does seem like they might have a significantly shorter duration of ICU stay. So melatonin's something to think about. Otherwise, there are no medications that have been shown to prevent delirium in the hospital. And we can talk about the non-pharmacologic stuff because that's where the money is for prevention. But we can also talk about that as we talk about the treatment of delirium. So then you go from prevention, it didn't work. The patient is now delirious, like the patient in the clinical study
You mean this case from Cashlack?
Our Cashlack case.
A totally
Mr.
believable name.
Mr. Dolman?
Mr. Dolman.
Poor guy.
So he sure sounds delirious, and we should do our test on our questioning of him to make sure he's delirious. But he sure seems delirious at this point. So how do you actually treat him? And again, it comes down to the fact that really you don't want to treat him overall with any medications. Benzos don't work unless you are in withdrawal. So don't give benzos to this patient. Acetylcholine esterase inhibitors, they don't work. So don't give that to him. And antipsychotics, even though they've been trying to use them or meds like them since 1949, they don't seem to work either in all of the systematic reviews that have been coming out in the last few years. There are a couple studies. There was a study from 2005 and a study from 2010 that made it look like there was possibly some benefit of giving haloperidol or quetiapine, but both of those studies, the first one, the 2005 study, was actually supposed to be a study of preventing it, but then when people got it, they were still getting the haloperidol, and it seemed to help. So that was a secondary endpoint in that study. And then the 2010 studies of a study of 40 patients with quetiapine, and it actually didn't help on days 1, 3, or 10. But if you look at all of the days put together, maybe it decreased the severity. So very little good data that it helps. And then all of the systematic reviews, and there were just another one in 2019. And actually, a lot of these systematic reviews have been done from my colleagues at Johns Hopkins. So I believe them innately. Those systematic reviews all show that antipsychotics actually do not help patients who are delirious. And the Geriatric Society, the American Society of Geriatrics, said that prescribing practitioners should not prescribe antipsychotics or benzos for the treatment of older adults with post-operative delirium who are not agitated and threatening substantial harm to self or others. And I think that is true whether it's post-operative delirium or whether it's delirium on the medical service.
And let's remember, these have an FDA they have a black box warning for atypical antipsychotics since 2005, and I think since 2007 or so or 2008 for the original antipsychotics like haloperidol.
Yeah, there are real risks. There are EPS symptoms that happen with this. There's aspiration pneumonia that can happen with this. There's arrhythmia that happens with this. And yeah, it's particularly black boxed around the treatment of dementia patients because they find more of them die. So
that's bad.
That's bad.
Starting at 30 days.
So we don't want to then extrapolate that to our patients who are just delirious by trying to kill them by giving them antipsychotics in the hospital. I guess then the question, and maybe I'm asking a question myself, but maybe I should let you all ask questions, is what do we do then if we're not going to use antipsychotics?
You're reading our mind. You're
doing great.
Bring us home. Bring us home.
So as I continue to ask questions of myself, so the first thing is don't leave in IVs if you don't need them. So that patient who's picking at the IV, get that IV out if they don't need them. And then there are people, this is not supported by data, but if you need to keep the IV in, there are a lot of people who suggest that you can take well-taped gauze and extend it from the wrist to the shoulder with any attached tubing exiting out behind the shoulder, and the patient will play with the gauze, but then leave the IV alone. So that is something to try. Another thing is, as I think Tony and I would agree all the time, don't draw blood if you don't need to draw blood. Don't take vital signs if you don't need to take vital signs. Leave the poor patients alone and do the things that we know can help patients both prevent it and then probably treat it. And that's things like get rid of problem medications, treat the withdrawal, correct the metabolic disturbances, let the poor person sleep. We don't let patients sleep. Get the patients mobile. Oftentimes, we come up about 30% of the times with patients should have bed rest. And then if you look at total amount of time of patients out of bed, it's like 43 minutes that they're out of bed. So 90% of the time they're in bed. So get them up and moving. And then, of course, get out the things that are holding them down to the bed, like the urinary catheter and other lines that they don't need. If they have an infection, treat an infection. Try to get them out of that semi-private room that is really noisy. It's my favorite euphemism, semi-private. I believe that no privacy in semi-private. And then you have the crazy neighbor who is watching TV until 5 a.m. and your patient is not falling asleep. Get them into a private room so they can actually sleep. And then a lot of people say, make sure you are treating their pain adequately. So there are things to do to try to treat their delirium, which are also probably most of the same things that you would do to try to avoid delirium in the first place.
Talk about low-hanging fruit. There's been a couple articles that I've seen in the past year or two just talking about this, like how poor of a job we do of just like normal things, like just getting just common sense, getting the patient to move, stopping unnecessary labs and vitals, and just letting the patient sleep through the night if there's no reason to check their vitals in the middle of the night. It is so hard. Like, you put signs on the patient's doors and in the room, and then I come back the next day. I'm like, did you get sleep last night? They're like, no, they still woke me up and did my vitals. Even if you it's just hard to get it to stop.
Yeah.
Well, the sleep thing specifically, like the fact that the medicine interventions that were the most efficacious are the ones that let patients sleep. They either give melatonin or meltion. Like, it's the things that not knock them out, but patients that sort of sleep soundly through the night are the ones that seem to actually have effect. Yeah. So just let the poor people sleep.
Let them sleep. And have you guys at Cashlack, have you seen the activity vests?
No, these were, I don't know if these were I don't know. I was thinking about them. I'm like, it seems very practical, but if I knew that in the future I'm going to be put in an activity vest, just playing around, but I guess it's better than being tied to the bed and given Haldol.
It's happening.
Haloperidol.
Yeah, we have them at Hopkins. One of my patients was wearing an activity vest the other day and was totally playing with the vest and not messing with the IV. It was really impressive.
Yeah.
And you probably have them at Cashlack. You probably have them at your hospitals. You just need to ask for them. And you don't even know that you have them.
So it's got buttons and zippers and all sorts of things.
Exactly.
When we need activity vests, it's just going to be an iPhone. They're just going to give us an old generation iPhone.
It's the kind of stuff you give your 15-month-old.
Yeah. Or a Mac.
Exactly. Stuart, come on. Mac might want to sponsor the show someday.
They do not.
Yeah. All right, gentlemen, I think we have to start wrapping up. Tony, we'll start with you. Want to give us any take-home points, and then we'll go back to Lenny for his.
Yeah, so I think the key take-home point for supplemental oxygen is, I think the listeners need to remember it's a medication. And so you have to have a good indication for it, and you have to have parameters for its use. And just knowing those parameters is obviously a secondary importance, but just starting with that, it can be harmful, and we have to treat it as a medication. If we just recognize that, we're going to make a lot of progress.
Lenny?
So I'll go with two. One is for your patients who have acute MI, for your patients who have acute decompensated heart failure, likely for your ICU patients, if they have a potassium of 3.5 to 4.5, that is totally fine. Don't mess with it. Don't buff it. Leave it at 3.5 to 4.5. For your patients who are delirious, leave the medications alone and try all the non-pharmacologic stuff that we know helps.
Okay. We will leave it at that. Did you guys want to plug anything?
Absolutely. So in September of this year, there's a teaching physiology on the fly course taught at Mount Desert Island in Maine. If you love popovers, like physiology, and enjoy crisp weather in Maine, you couldn't do any better. I think, although Paul, were you the one who said that you'd go there for I forget, there was something you said you'd go there for, and it wasn't any of the things I listed.
I have no memory. No, I Maine seems nice. Sure.
They have good lobster.
Yeah, sure.
The lobster it's actually a great course.
All right. Thanks, guys.
Thanks for having us.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul, because we're committed to providing with high-value, practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecurbsiders@gmail.com. A special thanks to our producers for this episode. That would be Burton Shin, 4th-year MedPeds resident at Brown, and yours truly, Justin Burke, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, and Chris, the Chew Man Chew, on Facebook. Until next time, I've been Stuart Kent Brigham.
I have been Justin Lee Burke.
And I wanted to thank Stuart for composing our theme music and thank Claire Morgan at Notterly for editing our audio. Until next time, I've been Dr. Matthew Frank Watto.
And our main Dr. Paul Nelson Williams, thank you and goodbye.
Hey, Paul, I got a question for you.
Oh, no.
What did the heart say to the lungs after the oxygen fairy came at night?
You're going to tell me no matter what I say.
Yep. It's oh, that's rad. No.
Let it sit. Just let it sit. Claire, keep all of this. All right, I'm hitting stop.